I'm Tony Mills. I'm a senior fellow here at the American Enterprise Institute. Want to welcome you all. Thank you for coming, particularly those of you who braved the Friday before the holiday weekend to be with us in person, but also thanks to those who are tuning in virtually. What I thought I would do is, before getting into our panel, we have a terrific lineup today, two excellent panels. I'm really excited about the discussions, which will cover a range of important and substantive issues relating to the COVID-19 crisis. But I wanted to start by just saying a few words about why we're having this event here now, by way of background. So I think it would be uncontroversial to say that the COVID-19 crisis was, in fact, a crisis. However we think about it, it's something that we will all be grappling with for some time to come, certainly among the most important events of recent times. Of course, it was a public health crisis, arguably the worst in 100 years, which resulted in an unspeakable amount of death and illness. But it also has resulted in a set of policy and political decisions which were unprecedented, the effects of which we're still grappling with and trying to understand. And the effects of COVID, I think, can be measured not only in terms of the massive amount of carnage, but also the secondary effects of the crisis. I think in terms of learning loss, mental health issues, other sorts of medical problems that were exacerbated by the crisis, but also the effect that the crisis had on our social fabric and our political life. If you spend time reading the history of epidemics, which is a demoralizing exercise I don't necessarily recommend, you'll find that this is a very frequent pattern. That one of the worst effects of epidemics and pandemics is to cause a social conflict, political conflict, and an erosion of social trust. And I think we see that today, and we'll be grappling with that for a long time to come. So all of that would be reason enough, I think, to have serious reflection on what happened during the COVID crisis, what we did well, what we did badly, what lessons we could learn. But there's another, arguably more important reason, which is that COVID is surely not the last public health crisis we will face. It is very, very likely not the last pandemic we will face in the years to come. And so while recognizing with, I think, humility that there are certain deep patterns that can recur when crises like this face us, we're not helpless, and we do have tools that we can use and draw on to think about how to grapple with crises like this. One thing I think we could all agree on, regardless of our politics and what we think about COVID, is that we did not handle COVID very well, that the response, particularly in the United States, is not an exemplar of good governance or good policy. And the question that we have to think about today is how we can do better next time. What kinds of lessons we can learn for policy, for thinking about how we use evidence for policymaking, which is the subject of our first panel, but also how we think about institutional reform and building resilience into our federal and other institutions, which is what we'll talk more about in the second panel. As the crisis recedes, the window in which to learn those lessons risks closing. And it's for this reason that I think we need to have this conversation now. One might have expected a national blue ribbon commission to look at the COVID crisis and to think about what we did well and badly. So maybe something akin to what happened after the 9/11 attacks in 2001. Demoralizingly, we've seen surprisingly little action of that kind here in Washington. Relatively little compared to the scale of the crisis and its importance for thinking about the future. As it happens, a group of experts did get together in 2021 with the purpose of trying to create a commission like the 9/11 Commission, and had inadequate success among policymakers in putting something like that together. Fortunately for us, they decided to press onward and formed the COVID Crisis Group, which was an independent group of experts that tried to examine what we did well and badly during the crisis and put together a set of recommendations for how we might move forward. And this these recommendations came together in a report, a book called Lessons from the COVID War that was released just this past spring. And so part of what we wanted to do today is highlight the work of that report and engage with its findings and recommendations. And so we're fortunate to have a member of the COVID crisis group on each of our panels today. So we hope this will be the beginning of a set of conversations, only the start of more to come, and we're honored here at AEI to convene this and to contribute to that in a small way. So without further ado, I'd like to introduce our first panel so we can hear less from me and more from the experts. So joining us on our first panel today, we have Mark Lipsitch, who is a professor of epidemiology at the Harvard Chan School of Public Health and director of the Center for Communicable Disease Dynamics. During the pandemic, he was named the founding co-director of the new Center for Forecasting and Outbreak Analytics within the Center for Disease Control and Prevention, where he now serves as a senior advisor. We also have joining us Emily Ricotta, who's an independent research scholar in the Division of Intramural Research at the National Institute of Allergy and Infectious Diseases, one of the divisions within the National Institutes of Health, where Emily leads the Epidemiology and Data Management Unit. Last but not least, we have Jonathan Fuller, who has the dubious distinction of being a fellow philosopher like me. He's currently serving as a visiting scholar in the Department of Bioethics at the National Institutes of Health. He's also a professor in the Department of History and Philosophy of Science at the University of Pittsburgh, as well as a co-founder and deputy editor of the excellent journal, which I recommend, Philosophy of Medicine. So with that, I'd like to pass it over to Mark.
Thanks, Tony, and thanks for the invitation to be here. I'm glad that this panel is happening. I think it's a really opportune time. It gets less opportune by the day, so the sooner we discuss these things and reach some understanding of how we can move forward together, the better. I should say that although I do hold a part-time secondment to the CDC, I'm speaking in my personal and academic capacity, not as a representative of the CDC. I was one of the people that was on the COVID crisis group, which produced this book that many of you may have seen, and Lessons from the COVID War. And Tony asked me to say a couple of words about the process of that. So, as Tony mentioned, the original idea was to be the sort of groundwork layers for a full-scale investigative commission that might be set up by the government or in some other way. And that began in 2021 through the efforts of for Philip Zelikow, who led the 9/11 Commission as the executive director, and who worked with 4 foundations, the Schmidt Futures Foundation, the Rockefeller Foundation, the Skoll Foundation, and Stand Together to try to get some diversity of funding and diversity of viewpoints on the planning, what was then the COVID Commission Planning Group. And he began assembling that group through a sort of snowball process of interviewing people who had been involved in the pandemic in various ways, asking some of us to, after the interviews, to come and join the group that was doing these interviews. And so we sort of assembled in that way. And as Tony said, the goal had been to put together documents and oral history and some fresh memories for the potential future commission. And as we all saw, that was not adopted in the various pieces of legislation that could have adopted it. And so the book was written. Really by Philip, which is good because he's actually a great writer, and some of us are not all as good writers as, most of us are not as good writers as he. And I won't go into the details of it. I do recommend it. I think one of the things that's good about it is that it's extremely readable because of his ability to write well, even about kind of bureaucratic and institutional history, which is, we've all read books about those topics that are not well written. And it's a lot easier to write about personalities and individual stories. But the goal really was to write about the systemic issues and what was decided, how it was decided, and why it had, in many cases, to be decided in certain ways that led to less good outcomes than we would have liked. But I think that's part of the value of the book, is that it does have individual characters, it does have stories, but it really focuses on the structures and on the unfortunate fact that had we had the best leadership possible at that time in all parts of government, we still would have had a really uphill battle. There were some clear failures of leadership, and those are discussed in the book, but the system really was not designed. It talks about the sort of Grover Cleveland era design of our public health system, and the analogy between the way that we deliver public health and the state militias under the Articles of Confederation. So that gives you a taste of the kind of level at which it's written. And nonetheless, it's easily readable. So I think I'll leave it there. We'll come back to some of the topics that are in the book during the course of the discussion. I think I'll now sort of shift to a few perspectives of my own that I think are consistent with, but probably not all in the book. But I think, yeah, seriously consistent with what the book tries to lay out. So the topic of our panel is the role of science in pandemic decision-making. And the perspectives that I want to bring are to start by thinking about the kind of time evolution of that question. So the pandemic at all of its phases was an exercise in decision-making under uncertainty. And the uncertainty in many ways was greatest at the beginning and narrowed as it went on and as we learned more, but it persisted. And I think it's helpful to think about how you should act in relation to the science when the science is minimal, when it's somewhat more established, and when it's more mature, which we could think of as kind of the beginning, the middle, and the later phases of the pandemic. So in the beginning, there's a need to kind of be precautionary and use shreds of evidence, even shreds of indirect evidence, to make policies that will delay the bad outcome. And I think there was a process of education that happened at the beginning of the pandemic where people started to understand what it means to have an exponentially growing threat, which can be small today and large tomorrow, and where small is easier to control than large, and where delay is the name of the game, in the sense that, as we found in this pandemic, if you got COVID in in April of 2020, you faced overloaded hospitals, very few medical countermeasures, very little evidence about what countermeasures might work, and so forth. If you got it a year later, people knew how to treat the disease. There was not yet an antiviral that was specific and good, but there were steroids, there were other procedures in the hospital. You were much better off. And if it wasn't New York at the height of its first wave, you were also less likely to be in an overcrowded hospital. So delay is valuable. Flattening the curve, as hackneyed as the term became, really does mean that fewer people get infected over the course of it, as well as those who do get infected later. And so really you're trying your best as a society to delay the spread. We didn't do that as well as we could have, and that was one of the biggest issues. I think it's important to mention the issue of sort of the complementarity of following science in that environment. I was one of the few people that, among my friends, who was in favor initially of border restrictions. It was not a popular view among many public health experts, but in retrospect, I made an assumption that was wrong, which was that if we could delay entry by a month or delay the spread of the virus by a month, we would have time to prepare. But in fact, that delay is only useful if you have time to prepare. And because we weren't doing much preparation, in February and March, that delay was not as valuable as it could have been. So I think I was right on the principle, but wrong in the event. As you get to the and the precautionary approach means that you do a lot of interventions that should be marked very big with a very big red asterisk as temporary and based on our current level of ignorance. And school closures, which I think we'll get to later, is a good example of that. It was absolutely the right thing to close schools initially because we didn't know what the role of children would be in spreading it, and it made it made a lot of sense given our understanding of how many respiratory viruses spread. But it should have had an asterisk saying this is based on what we know, and we're going to revisit these decisions. And I think that's a general issue that I'll mention in a second. As the pandemic wears on, evidence begins to accumulate, but it often is not decisive. And so the need to integrate evidence from different sources, from social science, from economics, from biology, from randomized trials of particular interventions, becomes more necessary. And as we try to figure out how to live with what turned out to be a very long-term threat, the goal really has to be to make sense of different kinds of evidence, none of which is completely conclusive by itself, and to treat it as a multiple input decision-making problem. And then I think Emily will probably talk about this some in much more detail, but I think in the later stages, what struck me was the importance of observational evidence as opposed to randomized trial evidence. Most of what we know about the vaccines right now and the clinical decisions that all of us and our healthcare providers make are based on observational studies because we didn't do trials with this variant, with this number of vaccines, with this immune history. There are just a lot of things that we can't do trials on, and we have to understand the value of observational evidence and take steps to make it better. I want to finish by saying a couple of things I think we can learn from other countries' responses and how they integrate science. The US has among the most informal processes in major industrialized countries for integrating scientific input into government decision-making on public health, and putting aside the FDA where it's quite formalized, but for decisions of the sort of many of the kinds that we had to make in the pandemic, there was no centralized group of experts who filtered evidence from science into policymaking. In contrast to, say, the United Kingdom, where there was SAGE, which got many criticisms and is not perfect, but it is a formal structure to filter evidence and provide decision makers with a sense of what the scientific community believes, including the dissent within that scientific community. Another lesson, and I think that happened informally, particularly in many states. There were councils of advisors assembled, but there was no structure, and those, I mean, I was on the one in Massachusetts for the governor, on several in the Massachusetts for the governor, and because it was informally assembled, that meant it was a several-hour-a-week time commitment, not a many-hour-a-week time commitment, and nobody had the time to really, couldn't respond to formal requests for evidence, for example. Another thing the UK did very well, and I'm focused on the UK because it's the one I know the best and because it was one of the best in terms of evidence, was to put in place structures to gather evidence. They put in place 2 large surveillance studies that made them understand what was going on at a regional level at all times in a very comparable way across jurisdictions that we never had. And then there's the preparedness aspect of putting in place data structures and data authorities for the federal agencies to collect data from the states, and structures for reporting from states and from healthcare to be more effective. And there's a whole discussion to be had about that, but I'll just leave it as a teaser there.
Thank you so much for having me here today. I am an infectious disease epidemiologist at the National Institute of Allergy and Infectious Diseases. However, I am also here in my personal capacity today. Any of my opinions, anything that I say are my own and don't represent that of NIAID or the US government. So I'm really here today to talk about data. So a lot of what Mark said, having to get that evidence, having a lot of misunderstanding and uncertainty as we moved throughout the pandemic, how we answer those questions, how we become more certain is by gathering data, doing research, having surveillance systems, all of those things. And unfortunately, data is difficult to collect and manage, even at the best of times, but it's certainly made substantially more difficult during an epidemic or pandemic situation. And so we really, today I really want to talk about some of the things that went wrong, some of the things we could have done better during the pandemic in terms of data collection and surveillance and research. I do want to point out that there is a difference in the reasons why we collect data, how we collect data, and where we collect it from based on whether we're trying to understand where a disease is spreading in a community. So disease surveillance, we want to know how many cases of an infection are in certain locations. This differs from whether we're trying to answer questions of, well, how well does a vaccine work or how well does an intervention work? And so when we talk about these data systems, we need to separate surveillance and research and other data needs because it's not all just a one-size-fits-all data collection. Not all data is going to answer every question. So that's really what I want to talk about today. My expertise is in the design and conduction of clinical studies, non-observational studies in particular, as well as how and why we collect data, how we use it, how we manage it. So that's what I am hoping to bring to this discussion. I've had the opportunity to work at a state health department. I've worked in academia. I've worked with some CDC-funded programs for surveillance. So I've had a unique opportunity to really understand data collection and use from a wide variety of different areas. So a couple of problems that I want to highlight that we ran into during the COVID pandemic, although are not surprises to anybody who has done research or surveillance, it's difficult to collect and manage large amounts of data, particularly sensitive data. So we have to remember that in a pandemic, you're collecting information on people's health, on who is sick, on demographic information about them. We learn a lot about people through the illnesses that they have, and that information gets reported. And people can have various feelings about that. Some of us don't mind having that information shared. Other people have reasons why they might not want that data to be shared. And so we need to ensure while we're collecting all of this data, we're doing it in a sensitive manner. We're doing it in a way that can protect people's privacy, people's information. And that's difficult to do, especially when you're trying to connect data systems across different platforms. We need to collect data in a real-time fashion. So having data from 3 weeks ago doesn't really help us if we're trying to respond to a pandemic. So we need to have data on how many people are getting tested. Are those tests positive or negative? Are people able to get treatments? Are they taking those treatments? All of these things, we need them in real time to understand how the situation is evolving and to understand how we can actually respond to it and how well those responses are working. Otherwise, why are we investing in any of these interventions or things like that? So it's not only is it a public health thing, but there's also that economic consideration too of making sure that we're using this data to help inform how and where we're doing our public health response. In addition to it being collected in real time, we need some sort of standardization. So just having a bunch of data is better than having no data, but it takes a lot of time to manage data. We in the data science world, we joke, we spend about 70% of our time cleaning data that other people hand us and only about 30% of our time actually doing research with it. And that goes for surveillance as well. So if you get data, in the US, we get surveillance data from state and local health departments. We can get data from healthcare companies, from Center for Medicaid Services, all over the place. And none of these data systems are standardized or meant to work with one another because that's not how our system works in the US, which is problematic when it comes time for a pandemic, and we need that data to be interoperable, to be able to be joined together so that we can say, okay, we may not have one federal system of data, but we have lots of different data that covers and answers what we need, so let's bring it together. So we need to be able to collect that data in real time, and we need to be able to have it standardized and interoperable, and then we need to have people who can actually analyze it and utilize it, and we need to be able to get that data from the people analyzing it up to our decision makers, who can then make those decisions based on the data and then provide a response. And unfortunately, in all of these different settings, the United States has fallen short in a pandemic situation. Mark mentioned, we don't really have those oversight organizations who can take data and the things that we find from it and make it actionable. So that's one of the things the report talks a lot about. I hope that we get to touch on that more today is, who maybe is responsible for taking the data and the insights and actually making them actionable. So there are, as I mentioned, we have surveillance, we've got research, and so we have different places that we can get data from. A lot of people just think, oh, data appears. Oh, I wish that were the case. It doesn't, not in the United States anyway. And so we can get data from surveillance systems. We have existing surveillance systems in the US. The CDC has the Emerging Infections Program, where there are pilot states around the country who report data on certain diseases to the CDC, and the CDC collects information. Each state has a list of reportable illnesses that somebody has it, they get to the doctor, they've got salmonella, that's got to get reported. And so we have these systems in place. There is data capture, there is electronic transfer to the CDC. And so one of the things that I think we could talk about is the potential to strengthen those systems, to really pay more attention to them, invest in them, and expand them as one way of helping fix the problem of this lack of data that we have, although there are many others. We also collect data by doing studies, observational studies. So these are studies where you're not randomizing people to a particular intervention, so randomized controlled trials are our gold standard, but we can't always do them, like Mark said, or they're expensive. You have to set them up with mindfulness and standardization and protocols, and that takes time. It can take money. You can be in a place where there's just no way to get enough people enrolled because there aren't enough cases, or cases already blew through and now everyone's immune. So there are a number of reasons why we can't necessarily use a randomized control trial, and we have to turn to something else, such as observational studies. The problem with those, again, standardization. So we don't have, at this moment in time, there's not been much work done on standardizing observational studies, on making, pre-thinking about protocols and case report forms, things that we could absolutely spend some time on and prepare for, and then have them ready when a pandemic situation emerges, and then take those into the field and collect that data, which can then be used to help inform in place of maybe lacking surveillance systems, maybe in place of where you'd want to do a controlled trial but you can't, or as we did in the pandemic, we had our vaccine studies, but that left out large groups of the population. We weren't able to include pregnant women in early randomized controlled trials of vaccines. We didn't talk about people with immune compromises. And so what do? We have to rely on observational studies, post-market evaluations to assess efficacy of interventions in those populations. And so standardizing that, making sure that people have the money and the people to actually do that work is very important, and it's something that we should be discussing in terms of its own preparedness initiative. Finally, we have real-world data, as the FDA calls it. This is things like electronic health records. And we use this data all the time for research. It could also be an opportunity for surveillance. In the United States, though, we don't have a centralized healthcare system. I don't know if all of you knew that, but And so our healthcare relies on working with companies, working with different systems at every single hospital in the country. And those systems are not easily accessible. They're not necessarily required to send in any data to the CDC in general, or in the event of an emergency. They're certainly not interoperable. I've had the opportunity and misfortune of having to work with a couple of them. And they can be very difficult and time-consuming to work with. And that really slows us down, and that really delays our ability to respond to an emergency. And so, another area of opportunity, I think, is to really figure out, well, how could we work with these corporations, with these healthcare systems who collect a lot of our real-world data, and how can they help us respond to a situation, get the data that we need to answer questions, do research, do surveillance. So there's a lot of opportunity, I think, to work with the data, to improve the data, and having better data will enable us to prepare and respond to outbreak situations in a much more efficient and concise manner. So that's what I'm here to talk about today, and I'm looking forward to the discussion about that.
Thanks to my co-panelists, thanks to Tony and the American Enterprise Institute. The third and similar disclosure is that I'm here talking on behalf of myself, representing my own views and not those of my institutions. So we heard a lot about data, and I want to turn again to thinking a bit about evidence, a related concept, roughly when we use data to support certain conclusions or certain decisions. And I want to talk also about evidence-based policy, which is a term that's often thrown around in government, sometimes in public health, and can mean different things to different people. On some readings, evidence-based policy just might mean using some kind of data or rationale to support decisions. But the expression evidence-based actually comes from medicine in the 1990s, the first evidence-based discipline, evidence-based medicine, which brought with it a number of different principles and heuristics for thinking about evidence, some of which are quite useful in a pandemic, especially when we're trying to evaluate trials of novel therapeutics, but some of which might be awkward or inappropriate. So the ideas of evidence-based medicine can be boiled down to a few. Orthodox EBM, or evidence-based medicine, says that the highest quality evidence comes from randomized controlled trials of the kind that Emily mentioned, in which we're randomizing units, usually individuals, but sometimes communities or groups to different treatment arms in order to compare the relative effectiveness of different interventions or policies. And also, we might want to synthesize evidence in a certain way by doing a systematic review of the literature, and where possible, pooling the results of multiple similar trials together in what's called a meta-analysis to come up with a kind of singular estimate of the quote-unquote effect of an intervention. That's often done with drug trials, in which we have a similar intervention that might, in some cases, have a similar effect on different kinds of people. In other cases, it might not. And in which the effectiveness might not be that dependent on, let's say, social context. Another idea that often travels with evidence-based medicine can be summarized by the phrase too much medicine, which is a movement popular in the United Kingdom and also here in the United States and elsewhere. And this is the idea that medicine, especially in recent decades, has been prone to overtreatment, overdiagnosis, too much medicine. And so sciences like clinical epidemiology can serve as an important check on unbridled medical enthusiasm by making sure that we're only using those interventions that are supported by the best evidence that shows that they're effective and safe. And that's more of a political kind of bent to the evidence-based medicine movement that might temper a kind of interventionism or interventionist strain. Okay, so what do we need for evidence-based policy in public health? I suggest to you that we need to think a little bit differently. Like Mark mentioned, we need in public health science and decision-making to rely on a diversity of evidence to answer the diverse kinds of questions that we want to have answers to. We want to understand the mode of transmission of a pathogen, infection fatality rates, the role of schools in transmission, the role of therapeutics, the role of vaccines, and different policies in order to mitigate transmission and so on. And different kinds of evidence play different roles. We wouldn't use a natural history study in which we're not intervening in order to understand the effectiveness of an intervention, obviously. So that means that we need a kind of approach to evidence-based public health that recognizes the value of diverse evidence, including evidence beyond randomized trials. We also need diverse modes of thinking and reasoning as well, partly for a reason that Mark mentioned, and that's that in an evolving public health emergency, there are just different phases in which we have relative amounts of uncertainty and different amounts of data and evidence available. We might reason in a more precautionary fashion early on, and just require having modeling results or evidence or data that makes plausible certain assumptions and outcomes, or plausibly supports the use of certain policies that we might then collect more data on and reevaluate as we go along. And so relying on just the highest quality evidence at that early stage might, on the contrary, actually lead us to be too cautious and not act in order to avert a catastrophe. So because we need diverse evidence, we also need diverse experts. And public health science is an interdisciplinary field. We need diverse experts to avoid blind spots that particular scientific disciplines might suffer from, as well as to kind of reason together to come up with an understanding of complex health problems. And a pandemic is a prime example of a complex health problem. But this, of course, means that different scientific communities that are used to handling different kinds of evidence, experimental evidence, observational evidence, could end up butting heads or clashing or having differing understandings of what kinds of studies we need and what kinds of studies are appropriate. I think partly to deal with this challenge of the need for interdisciplinarity, but the fact that different disciplines have different ways of thinking through evidence and decision making, I actually want to second Mark's call for a scientific advisory group for emergencies in the United States, a SAGE group, similar to what they have in the United Kingdom and also what advises the World Health Organization, as a kind of standing group that's there in interpandemic periods that involves all the relevant kinds of scientific expertise from epidemiology and other public health sciences, as well as from social sciences, including economics, that can help to answer important scientific questions in between public health emergencies, and to think through what kinds of evidence or processes we might need when an emergency hits. That's independent of government, both for the perception of having freedom from political interference, but also actually for the purpose of being relatively independent of political influence. And this is a group of people that shouldn't be ad hoc, but should be there, as I mentioned, in between crises. And the second thing I think we need government institutions to lead the way on preparing for the kinds of research studies we might want, having dedicated funding streams for these, coming up with protocols in order to standardize research across multiple areas when it comes time to collect the relevant data, identify important priorities for research and gaps in research, and then be able to kick in and partner with private and public groups based on existing relationships in order to get the studies done quickly when we need them. These tasks shouldn't just be left to academia, even though academia did a great job during the pandemic at answering many of the questions that we needed to have answered. Okay, second thing I want to say is that was under the heading of kind of evidence-based policy fit for public health. But we also need to talk not just about evidence when we're talking about evidence-based policy, but we also need to talk about values and reasoning. So we hear phrases like evidence-based policy, follow the science, which are kind of banal to us by now. Oftentimes they're invoked just to kind of put a stamp or justification on a policy, and sometimes one might be doing no more than saying, look, there is some data, there is some evidence that might be relevant to this particular problem. But data, as I suggested at the beginning, only becomes evidence when we actually use it to support a conclusion in the context of an argument we're making. And the argument we're making often depends on what kind of evidence we need and how strong that evidence needs to be. So I suggested that for kind of a precautionary reasoning or planning for reasonable worst case scenarios, we might just need modeling results, or we might just need evidence to make certain outcomes, bad outcomes, plausible. And that might be the best we're able to do in early conditions of uncertainty. On the other hand, if we're trying to justify mandating certain interventions, we might want to know specifically how those interventions might prevent harm to third parties, how they might stop the spread of infection, for instance, from one person to another. And when we're doing harm-benefit analysis and really trying to weigh the harms and benefits of an intervention, there we need lots of evidence about the diverse effects that our interventions have that might not be available early on. Okay, so this clearly requires not just evidence, but also it requires thinking about values as well. So what is it we're trying to achieve here? Are we trying to prevent harm to vulnerable groups that might have been made vulnerable because of a legacy of injustices that put them at heightened risk during a pandemic? It also means that because values and decision-making are necessary in evidence-based policy, that when groups disagree over the relevant values and decision-making, it can sometimes look like they're disagreeing over the evidence that's also relevant to making that decision. So it's sometimes can seem easier to say, look, I actually disagree with the values or priorities that you're relying on, but I'm going to criticize the strength of evidence for your claim, the poor study that you're using to support it, because that makes my argument against your position seem more objective and politically neutral. And so we have to make sure that we're not letting disagreements over values and decision-making masquerade as disagreements over evidence and policy, as they are wont to do in the heightened political environment of a pandemic. So if there's a more concrete proposal here, it might be that we need to focus on communicating the values and the kinds of reasoning we're relying on, and not just invoke data or evidence when we're justifying public health decisions. And we need to submit this to public scrutiny as well, and not just make data or evidence open for viewing. The last point I want to make is that it might seem trite, but in public health, we need public health approaches to problems and not just medical approaches, as important as medicine is during a public health crisis like a pandemic. That means that we need to think about epidemics according to what they really are. They're problems of a population. They have a life of their own. We need to adopt certain tools to understand them at the population level, and different ways for thinking about how to intervene and track the spread of an epidemic. So to give you a couple examples of this, we might deploy interventions for different purposes. We might employ face masks in order to protect individuals from becoming infected and harmed. And that might lead us to look for certain kinds of evidence that tells us whether or not they're good for a certain pathogen at doing this. But we might also want to look at the ability of interventions to stop spread to others. To pull in another example, testing for infection can have various purposes. It can have the purpose of surveillance. It can have the purpose of diagnosing individual patients with having disease. It can also have the purpose of screening individuals who might be contagious to others. And so in order to think about how to rationally deploy things like tests and treatments, we need to think about what kind of outcomes we're trying to achieve. And those must include public health outcomes that are directed at the community, and not exclusively outcomes that are directed at sick individual patients. So this is maybe one kind of philosophical way of supporting the common refrain that we need to support public health and not just clinical medicine, and that includes at the levels of regulation, policy guidance, and scientific advising as well. So I think with that, I'll leave it there and turn it back over to Tony.
Well, thank you all. So there's a lot of topics that I want to come back to. I thought maybe to begin, before getting into some of the weeds on standards of evidence that John was alluding to, which I'd like to probe Mark and Emily on as well. I thought one thing we could start with is thinking about what we did wrong initially. So this was a theme, Mark and Emily, a lot of what you were saying. So something that I think everyone agrees with is that as the pandemic unfolded, a lot of the interventions we had, were controversial, not always effective, and a lot of our polarization resulted from debates about masks in different contexts and ultimately vaccines and so forth. One of the ironies, of course, is that had we been better up front, we would have actually been able to be more precise in our interventions and had fewer hammer-type interventions. But the fact was that we didn't necessarily have a very clear picture on what was going on. So I guess the first question I want to ask both Mark and Emily is, why was that? What was it that we lacked that didn't give us the kind of picture that we would have needed in order to have early, more bespoke kinds of policy interventions to avoid the hammer type interventions we wound up with and that became so controversial.
So data, we didn't have the data. We also assumed that, the first cases really got into the US in March of 2020, when in fact it turns out we probably had people who'd come in infected earlier than that. And once once you turn on that tap, the water's running, you can't put it back up in the tap. And so not knowing that people had come in infected, where they were, who they might have been infecting, that all led to just compounding cases spreading where we had no idea. And so if you don't know, how do you intervene? Contact tracing works a lot better if you have one person and their 20 to 30 contacts than if you have 20 people and their 2,000 contacts. Everything increases exponentially as you go. So the earlier you have data, the earlier you know what the situation is, the earlier you can respond, and they don't have to be such huge disruptive interventions. And so I think that the lack of data, but also the lack of wanting to really believe that this was going to be a problem in America for us, I think definitely contributed to our early stumbling. This is really one of the first big times that a pandemic impacted Americans directly. Sure, we had some cases of Ebola that we had to worry about. Yes, we've had flu, but everyone gets the flu, right? So this was really one where I think more people wanted to just not have that data, not have that evidence, and say, well, we don't have anything to say that it's here, and allowed that to that ignorance, that deliberate not knowing, to let things get out of hand. And had we had data, had we had surveillance systems, had we started collecting things early, we would have known better how and where to respond.
Yeah, I agree with all of that, and I think it was partly willful decision to not respond in the first 2 months, in the sort of January, February. I was one person, but not the only person in February to say this is going to be a global pandemic and it's going to infect a majority of the people in the world, and it's going to be a big thing. And I wasn't the only one, because it was clear to infectious disease epidemiologists that if there are cases in dozens of countries, as there were by then, that it's the weakest link problem, that an epidemic spreading anywhere becomes a risk of an epidemic spreading to new places. And even if China, as it did, can control it at the source, once it's out in the rest of the world, it's really the weakest link, and the chance that it gets back in the bottle is nil. And we really didn't spend the first 2 months gearing up and preparing as much as we could have. And that includes preparing to gather better data. I think there were some specific institutional and kind of weedy things about the inability to use, for example, a study set up for flu in Seattle to detect COVID, which eventually was broken through, but that lost time, we could have had more flexible abilities to see what was going on had we planned our human subjects approvals in advance to cover a little bit more of emergency needs. But I think I basically agree with Emily that it was a lack of data, but also a lack of positioning the ability to respond to what was clear to many people was a threat, even if we didn't have the data to prove it was yet a threat in the U.S.
And one of the other things is that, and this is talked about a lot in the report, is that I feel like a lot of agencies didn't know whose responsibility it was to be responding to these things and collecting data. Everyone assumes the CDC is, well, it's an infectious disease, it's the CDC, but that's actually not the case. The CDC can make recommendations, but it's up to the states to do a lot of the response. If it's an imported case, the Department of Homeland Security actually has jurisdiction over certain imported infectious diseases. And so I think there was just a lot of confusion too about who should even be doing the responding and who should have been collecting this data and what's the purview of different agencies. And that's something that I don't know if it ever really got cleared up. The development of the White House COVID commission didn't really seem to help things. There was a lot of movement around in there. And so there was just a lot of confusion about responsibility early on too, which again slowed us down.
And then, one thing that we need in order to get the relevant data, and that the book talks about a lot, is we need to have the ability to rapidly scale up and distribute tests and the kind of tests we need to collect the information we want. So that we're able to, as the book kind of suggests, get an eye on where the enemy is, how quickly it's spreading, and then eventually to allow us to more safely return to work, school, and other environments, which it took Americans a long time to do, partly perhaps because we didn't have a kind of national testing strategy of the kind that certain groups, like the Safra Center, were kind of working on developing, and then eventually collaborating with others, such as the COVID Collaborative, in order to think carefully about. But like Emily suggested, there was no kind of national federal strategy for thinking about what we would need to do and how we would need to do it in order to surveil COVID effectively, and then also return people safely to their various environments. And so that requires, for instance, just having the production capacity in place, the kind of partnerships in place, in order to manufacture the tests once we have the sequence of the virus and are able to produce them.
Yeah, and another thing that the book mentions is the sort of lack of an industrial policy. So and of a pre-existing non-suspicious, or at least not overly suspicious, relationship between government and private industry. So it gives the example of South Korea, which, because of their example with MERS, a previous coronavirus, had established relationships with companies that could build tests and had set up the infrastructure, not the physical production capacity, to my knowledge, although maybe some of that, but the agreements and the relationships and the knowledge of who could do it, so that when this virus came, South Korea was in the position to scale up the manufacture of tests. That doesn't give you a policy, that's a separate problem, but at least the supply of tests. I mean, it's easy to point to the early failures of CDC in the development of the test, but an alternative or a complementary strategy is to have the capacity to build large amounts of them.
So I want to come back to some of these institutional questions, but before doing that, I want to get into some of the issues of evidence and data that you raised. So, John, I know something you alluded to in your opening remarks. This is also something that you've written about, is that one of the difficulties of grappling with complex problems where you have multiple kinds of expertise that's required is that you can have conflict among domains of experts and clashing standards of what constitutes good evidence or what kinds of methods we can use. And one of the sort of cultural clashes that you've written about is that between the domains in medicine and public health that rely on principally randomized control trials and evidence that's generated by that, and the domains that rely on modeling, especially if we're thinking about population level evidence. I wonder if you could just say a little bit more about those two approaches, and particularly how that shaped a lot of the debate about COVID, because I think part of what happened in a lot of these policy discussions is that we had public controversy, but if you sort of lifted the hood, you would find that it's sort of a complex situation within the expert community as well. And these two things were not always clearly identified, and it seemed to muddy the waters in some cases.
Yeah, I mean, I think one thing I want to start off by saying at the outset is that there's absolutely an important role for clinical trials, and especially randomized clinical trials in a pandemic. We need them to understand the effectiveness of novel interventions like vaccines. We need them in order to figure out which of the many possible repurposed drugs we might consider are actually effective and safe. And there are great examples from the UK with the recovery trial, with the REMAP CAP critical care platform trial in the United States, where they delivered good, high quality, and fairly timely results to help inform the care of patients. So I'm not somebody who thinks that we simply don't need clinical trials in medicine. But there can be more tension when we're thinking about the relative roles of different kinds of evidence in examples like face masks. And maybe I'll stick with that example because it's one in which right from the beginning of the pandemic to just a few months ago, there have been disagreements among different sectors of, you might say, of the scientific community who are used to dealing with different kinds of interventions or problems. So very early on in the pandemic, there was the question of whether or not we should be using face masks in order to protect ourselves or others. There were a few individuals in the evidence-based medicine community who pointed out that from previous reviews of the evidence, including randomized and non-randomized studies, face masks for other respiratory pathogens, studies of the effectiveness of those face masks were often of low or uncertain quality and didn't give us a clear direction of whether or not face masks might be useful in this pandemic. So arguing from a kind of lack of evidence, some cautioned against deploying face masks. They might be analogous to a drug that has some kind of theoretical plausibility, but ultimately turns out not to be effective. Others, however, who are possibly a little bit more acclimatized to the reality of public health decision making, suggested that there's another kind of approach we can take to the question of face masks, and that's that we can ask ourselves, what are the kind of worst case outcomes we're trying to prevent? What are the plausible harms of this intervention, face mask wearing? And given that there is some uncertainty about whether or not face masks might be useful here, is there a different way we can reason? Not asking ourselves how good is the evidence and is it strong? Is it high quality here? But rather on balance of plausible benefits and harms, is it a prudent thing to do to recommend wearing face masks, specifically for in the community among the asymptomatic? It's a different question about whether to wear face masks when you have symptoms of COVID, and there the guidance was a little bit more clear that it was a good thing to do. Fast forward 3 years later, when we have collected quite a bit more data on the ability of face masks to slow community transmission. Some of this is observational in data, for instance, looking at different regions that implemented different policies, mask mandates versus not, as well as 2 or 3 randomized trials comparing different individuals or communities that used face masks to slow community transmission. And so, despite the fact that we have some more studies in the context of the pandemic, and actually a wealth of different kinds of evidence from before the pandemic about the ability of face masks in the laboratory setting to stop transmission of respiratory particles. We have a wealth more evidence during the pandemic about the role of pre-symptomatic and asymptomatic spread of SARS-CoV-2 in community transmission. We have a wealth more evidence from observational epidemiology demonstrating that airborne transmission through small respiratory particles is an important and probably the dominant mode of spread of SARS-CoV-2. There still remains some disagreement among certain kinds of scientists. So a Cochrane systematic review, which is the kind of gold standard for evaluating evidence in evidence-based medicine, a few months ago did an update of the literature on face masks, focusing only on randomized controlled trials in which face masks were used during the pandemic, but actually principally in studies dating back before the pandemic, in the context of influenza and other viruses, and trying to revisit the question of whether or not face masks are effective, for instance, for mitigating community transmission, and concluded that that they probably had little or no effect based on evidence of variable quality, but often according to the review of lower uncertain quality in which adherence to face masks was highly variable, in which the settings in which the role of face masks were studied was also highly variable, ranging from providers in healthcare settings to community members living in villages, so essentially use this kind of orthodox evidence-based medicine approach of aggregating together the studies in order to come up with a single pooled estimate for the ability of face masks compared to no face masks to slow community transmission or decrease it, and then some studies as well comparing different kinds of face coverings, respirators to surgical cloth face masks. And so that review concluded based on kind of an orthodox evidence-based medicine approach that face masks are probably not effective. But if you look to many members of the public health community, they're unconvinced. Why? Because they're looking at a broader range and diversity of evidence, and they're not asking the question, what is the effect size of face masks against respiratory pathogens? They're instead asking, how can we understand the results of multiple different kinds of studies in context, and understand the roles of, the role and mechanism by which this intervention might play, might have a function or might have a role in mitigating person-to-person transmission. So it's not just that they're looking at a broader range of evidence, but also that they're looking at this evidence in a different way, a way that I would think of as kind of trying to explain the results of different kinds of studies holistically, rather than pooling together the results in order to come up with a more precise statistical estimate of a single effect size, which in this case just doesn't exist, because the range of studies that are being looked at are so heterogeneous in terms of the policies that are being studied, the context, the settings, the outcomes, and so on. So there really is no singular effect size of mask wearing against respiratory pathogens there to be found in the first place. So this is an example of a kind of what you might call scientific culture clash, where a certain group of people who are used to evaluating certain kinds of interventions in medicine using favored methodologies are trying to apply those in a different context, in which, to my mind, those methodologies have important limitations.
This seems like a good example of where needing space in which to have these kinds of debates and informing policy would have been very helpful, because it strikes me, listening to you, that the description you gave about the state of the science and the disagreement and the reasoning that goes into the policy recommendations is stark contrast with what we tended to get in sort of media and the public sphere, and I think arguably contributed to a lot of polarization and trust issues. I want to make sure that we have time for questions from the audience. So I've a lot more I'd like to ask, but if there are questions, please feel free. Start with Bob.
So back to Seattle.
I think, Bob, we have a mic coming.
You mentioned Seattle, and I'm curious your judgment about whether now, given the technical capacity that we have and the sequencing capacity that existed in that area, and the folks that were doing the testing knew that there was community transmission going on, did that information filter up, and would we make that same mistake again? Or do you think that the current policies would allow that information to start informing policy earlier on?
You want to take that one?
I'll start, but I'm certainly don't know the detailed timeline of where information got from that. I think part of the point I was trying to make really was that for a long time it was inconsistent with their human subjects approvals that they had to do. So their study had been reviewed as the Seattle flu study. They were not allowed to test it for other things, test the samples for other things. So there was a delay in being able to do that due to the limitations of how the consent forms were written. I think once the case was reported, I think it made national news, as I recall, and it wasn't a problem of getting the information out then. I think public health agencies always have the problem that they like to stick to data. They don't like to speculate. And I think actually public health agencies need to do some controlled speculation with again, asterisk saying I'm speculating now, this is not data, this is informed expert opinion. If there's a case in Seattle, which we found in that way, and there are cases in multiple other countries, then it's stupid to think there are not cases in lots of other places in the United States. The fact that we haven't seen them is sort of needs to be noted, but is not. But the story should not be we have a case in Seattle. The story should be we have a case in Seattle, and one role of infectious disease models and of epidemiological reasoning is to say, if there's a case in Seattle, we have reason to believe for all these other reasons that there are cases elsewhere and that we need to be preparing for that. And certain public health departments that were in conversation with good epidemiologists or had them themselves were thinking that way very early on, but not all.
And I think one of the things you're probably trying to get at is if an academic institution develops a great test, why can't we use that information rather than waiting for a CDC or FDA authorized test? And there's something to be said on both sides of that discussion. So should we maybe, as a country, be a little more flexible in allowing evidence to come from different sources such as academia? Yeah, I think so. However, is there a reason why every random Joe on the street can't, Elon Musk can't get into the testing industry, please, and just come up with any tests? There's a lot of garbage that can get out into the system, and we can run the risk of, if somebody has a false positive and we've got our policy that says, well, you have to stay home for 14 days, and now this person potentially loses 14 days worth of income when it was a garbage test and shouldn't have, that's when we get into trouble. And so we need to balance between innovating and allowing non-historically standardized groups who were the ones who always made those tests and always did. We have to balance incorporating them and allowing them to come to the table with also making sure that we're still following rigorous clinical standards, rigorous health standards, because there are implications for using this, for having this data, for being identified as a case, for putting money into that region because we think there's transmission. And so I think probably there will be more conversation now going forward about how we can incorporate different academic institutions or maybe private companies who come in, they have new genome technology. But I do think that we need to make sure that there are still standards and regulation there because it could go badly. There's a lot of damage that they could do that maybe people wouldn't think of initially because, oh, hey, it's just more data, it's more information. So.
Yep. The microphone.
So thinking about new technologies coming online and garbage in, garbage out, I'd like to ask you briefly about the wastewater approaches, which were essentially new technology that was deployed as the pandemic was unfolding and yielded some very interesting predictive forecasting information. And the much more recent use of large language models in the context of SARS-CoV-2 genomes as opposed to language to predict the future evolution of the spike protein. And in both cases, these are new approaches that have been historically outside the public health and medical arenas, but as a result of the pandemic, were deployed and are being deployed. And they certainly don't fit the mode of randomized controlled trials, yet they do represent where technology, and I would say bleeding edge, curiosity-based science can be deployed during a public health emergency to yield positive outcomes for the public. I'm wondering if any of you can respond to that.
Yeah, absolutely. So wastewater surveillance has actually been done for polio. We've used it as a mechanism for public health surveillance in the past. And so I think as long as it is done in an ethical fashion and it is done in such a way that it is able to answer the questions that you have, why not? If we've got money, if we've got people to do it, and why not have that data? I think maybe people disagree with me, but I think it's a great way. It also removes the need for humans in that situation a little bit. You take them out because you can observe their wastewater. You don't have to then have people going to the doctor. You can go into areas where maybe there's not as much access to healthcare. Maybe they can't get testing, but you can get their wastewater. So really, it could be a good way to innovate, getting information about people that are historically excluded from our surveillance systems because of other issues that we can definitely talk about. In terms of AI and the language learning, I actually think that this is a really great area for the utilization of that. You know, I'm an epidemiologist. I do machine learning. I'm usually very much a proponent of taking that carefully, making sure that we really think through. But when it comes to predictive modeling of things like spike mutations or target sites for new vaccines or things like that, we can really utilize AI. We have a lot of data, good quality sequences, you know, structural models of the virus and its different proteins that we can put in. And so you've got good quality data that you can put into an AI system and then model things that aren't going to necessarily immediately impact a patient and their well-being. And so we can say, okay, so maybe here are some different target options of spike mutations, and now we can design studies to test those and do that through a more traditional, you know, observational studies and then randomized controls if we need to. And so I definitely think that those are two instances of these newer technologies or repurposing of older technologies that we can use in a pandemic situation and in an environment where it's not going to, where it could contribute and add to our body of knowledge as opposed to adding more conflicting knowledge or adding more, you know, low quality evidence. So I wouldn't say, oh yes, let's go out and apply AI to everything, it'll save the world. Just as with mathematical models, you have to be mindful of how you're using them, how you're building them. Same thing applies, but I think there's definitely room for these newer technologies, given that we have people thinking through the risk-benefit trade-off, given that we make sure that we're using them in an ethical fashion, given that we have good quality data going in.
I think we have time for one more question. So right in the front here.
Thank you. Lou Gagliano. When we think about the fact that our healthcare system is both a public and a private system, we don't have universal system. The opportunity to make it better next time, how much of it is structural? How much of it is policy? And I know they're related. But how, and when you look at the two sectors, the private and the public side, the structural versus the policy side, how does that play out in your mind in terms of making it better next time?
I'll start. I think the federal structure of our public health system is the biggest constraint because it's probably not going to go away, meaning just decentralized and at the state or local level. I think that policies can improve our decision making by empowering those more decentralized units of government to use data and information better. And that's one thing that we're very focused on at our CDC Center for Forecasting Outbreak Analytics is working with state and local authorities to pilot and then spread the best analytic approaches, really as a hedge against federal national inability to respond. It's good to have capacity at multiple levels. There's a workforce issue there as well. And then I think at the same time, we need to redundantly, in a way, find better routes, as all the panelists have said, to get healthcare data, healthcare system data from the private healthcare system integrated into public health. That doesn't happen as much as it should. It does happen to some degree, but there's an opportunity to make it timely, in my personal view, to find better ways to collaborate rather than a sort of buying a block of data and transferring it, which means it's going to be old before you can use it, and that you don't necessarily know all the details of what the data mean, but to build collaborative arrangements with healthcare systems and public health to do analyses. That's one thing we're trying to work through also in the CDC Center. So I think the structure is in a way a constraint, and the policy can work within that constraint, but I think we have a lot we can improve through those kinds of approaches.
So unfortunately, we are out of time, and I want to make sure that we have a chance to thank our panelists and prepare for our next panel, which would also be terrific. So please stick around and join me in thanking our panelists.
We're going to move on to our second panel. I'm very excited for this, actually. One is I have my good friend, Dr. Janet Woodcock, who's the Principal Deputy FDA Commissioner and has been at the FDA for a number of years and has has helped reorganize and restructure offices and centers, and is probably one of the best executives I know in the public and private sector. And she has always been willing to do the hard work that others are unwilling to do and make the hard decisions. And then continuing our brain trust, we have Dr. Mark McClellan, who ran 2 federal agencies, including serving as FDA commissioner. And so I'm an eternal pragmatist. So this is fun for me because we are going to spend some time talking about how to fix agencies and organizations. Right? During the pandemic, the biomedical innovation complex worked pretty well. Right? We got vaccines, we had therapeutics. It took some time, but it happened in record time. And all of us are probably sitting here today probably because those things actually happened, and we eventually got them out into the community. The public health infrastructure, unfortunately, operated largely in a silo, fragmented across localities, states, and the feds. And then as we think about agencies, right, we had 3 primary agencies. We had the CDC, the FDA, and the NIH. And they all functioned very differently during the pandemic. And so my hope was to spend some time talking about how the FDA's successes, and it was not perfect, but it did a pretty darn good job, and what we can learn from that, thinking about how to fix the CDC and the NIH going forwards and make a more robust public health infrastructure. Dr. Woodcock, a few thoughts from you to start us off.
Well, I don't want to criticize my fellow agencies, but I would say that we don't have a systemic approach to medical product development, testing, and response. It's very, very fragmented, and all those cracks showed, like with the pandemic, right? And CDC struggles, I think, a great deal because of the distributed nature of the public health system. In other countries that had a more nationalized public health system and healthcare system too, were able to respond more systematically because they were unified and there was some kind of central approach, unified approach. So I think that we suffer from this, which we celebrate our federated nature, but we also we're victims of it in some extent because, from FDA's standpoint, say take the public health data, take the data about vaccination and its effectiveness. We relied on Scandinavia and Israel for those data. And everybody's beating up on us. Why are you quoting those data? But they had all the information. And I know the Biologics Center, who had set up a surveillance program, say for adverse events, off the health records. But the vaccine, who was vaccinated was not in the medical records because it was done through a different system. And the states, with their own privacy laws and their own approaches, we couldn't get those data. So we couldn't link adverse events or outcomes like did you get COVID or not. We couldn't link that to whether you were vaccinated or not. So we were unable to draw conclusions about vaccine efficacy and safety from the real world data in the United States. The CDC had a relatively, and when you say small, it's just the fact that you need many thousands of people. So they had an academic linked program that they were using for that, but that had such small data. We had some really bad problems with false signals, which is what you get with small data, that incomplete data, and so forth. For vaccine adverse events, vaccines are really, really safe. Or they should be, right? And so you need hundreds of thousands of exposures to look for adverse events, or you should. I mean, if you only need 100 people, then you don't have a viable vaccine, right? So And I think that was repeated. The same for, and Mark, tell me if I'm talking too much, and okay. So the same for, say, the clinical development programs. I was the therapeutic lead at Operation Warp Speed, okay? And so we funded, we funded a lot of stuff, and that was fairly successful. But there was not a clinical trials network in the United States we could utilize. The industry does in the United States most of the clinical development work. And frankly, the pandemic planning the U.S. had done presumed there would be influenza, pandemic flu, and there would be treatments already and diagnostics already and everything. And so the clinical development and evaluation was something that was completely neglected in a sense of thinking about how large of an effort that would be. And at the end of the day, it was the industrial efforts, the clinical trials and so forth in the United States that actually gave the leading data that we were able to, they did the vaccine trials. We were supported by Warp Speed, obviously, but industry did the therapeutic trials, supported to a great extent by Warp Speed, of getting, but not totally, that got these treatments available and vaccines available. Whereas the UK was able to put together the RECOVER trial through their national health system with large pragmatic trial and showed that a very cheap agent, corticosteroids, were useful in the late stage of disease, which is an ARDS type of problem. And, we've been, Mark, you probably remember when you were training, we've been arguing in medicine for 40 years about this, whether or not steroids should be used in ARDS. And at least for this type, for COVID-related respiratory failure, the steroids proved to be life-saving and are now, a cornerstone of the therapy. So, but they were only able to do that, cheap, widely available, could be used in any country, many different formulations of it. They were able to show that because they had a network, they were able to rapidly assemble clinical network. And I will say one more thing before I stop, I'm sorry. But I talked to Martin Landry, was one of the PIs over in the UK in this, and with his permission, I coined Landry's Law. And Landry's Law is that the number of patients enrolled at any site is inversely proportional to the number of professors. And I would say that, the NIH networks are all at academic health centers. Enough said, all right? Whereas the industry-preferred sites are usually not, because they are focused on patient enrollment and so forth. So, and they actually were the ones that delivered the industry sites. So I'll stop there.
So pulling on that thread, Mark, question, and something that we all have thought about, what makes an agency successful? And agencies are organizations just like businesses. One of the things we talked about is performance metrics and accountability and a clear budget. How do you think the FDA is distinct from the CDC and the NIH in that regards?
Well, the FDA, to picking up on Janet's point, has a very clear nationally focused mission. We don't have state and local, drug review boards. We've got one national system. I am concerned about some of the recent, court cases that have kind of challenged some of that, but we have one national system that is able to put a lot of expertise into answering questions about safety and effectiveness of drugs. And you just heard Janet saying, as we move into having better, far from perfect, but better post-market electronic data available, learning a lot more from real-world evidence too. And overall for FDA, that's tied to clear metrics. So a lot of the budget for the Drug and Biologics Center is related to being able to get to clear guidance to industry and clear response. And all of that came in very handy in the COVID response. I do want to back up a little bit in talking about metrics to where I think they really are needed. As you know, Mark Lipschitz and I were both involved in the COVID planning group effort, which was intended to support what could potentially be a bipartisan commission to look at what worked, what didn't. People really disagree on some of these issues now, but that's why you need kind of a deep, thoughtful, bipartisan look. We did it after 9/11. We've done it after other major national crises, and Phil Zelikow, who was involved in leading that, helped bring this whole effort together. We didn't get that commission. There was an effort by Senator Burr, Senator Murray, in the last Congress to get that over the line with some of the other end-of-year legislation, the so-called PREVENT Act. This one didn't quite come together. So it's very important to have meetings and discussions like this to think about like what worked and what didn't, and try to get past some of the kind of high-level talking points that people have. And one of the things we found in this effort was, the reality is a little bit different than what different people are summarizing. One of the things that's most critical here is that we don't have, and still don't have, a unified national strategy for how you bring different components of the federal government together so they can do each of the things that they need to do as part of an effort for national response in a crisis like this, and support the state and local responses. We are a federal government. We are a federal country. Every part of the country has somewhat different governance, institutions, capabilities, and that can be a good thing. So we're so diverse, but that means you need federal support to make it easier for the things that can and should be done at the local level to be done effectively. And FDA, working with industry, was able to do this, especially for warp speed, kind of signature success in the pandemic of getting vaccines tested at large scale, mass produced and available. The other components were more problematic. And you mentioned there's roles for CDC. There's also big roles for CMS. CMS proved once again that it's a critical public health agency with all these flexibilities that implemented quickly to deliver care at home and so forth. And CDC tried as well. I mean, we get back to some of the failures in all of these areas. But while we had the best treatments and vaccines, we had by late 2020, the largest availability of good diagnostic tests too, including ones that people can use at home, we did have some real problems in translating that into impact. And part of that, I know the CDC has been blamed for, and we can talk more about that too. Part of it, I think, goes beyond that, because any infectious disease threat going forward requires a different kind of response than we had in the 20th century. So it's no longer good enough to go door to door and find like a locally spreading infection and try to understand it, grow it in the lab or whatever. From now on, these infections can potentially spread globally super quickly, but we have the technology to manage that. Any new infectious disease threat should be something we should be able to sequence genomically in a matter of days, if that. We were able to do that with COVID. We should be able to produce large-scale, so-called PCR tests. This is basic technology, and make those available not only in public health labs, but in healthcare organizations that do most of the testing around the country. We've seen this happen with Mpox response now too. We should have treatments off the shelf because we know what kind of virus or infectious agents this is that we can apply. We can try to apply in the kind of testing framework that Janet was talking about quickly. We have synthetic biology that enables us to make monoclonal antibodies and other technologies, treatments in a matter of weeks to months, show that they could work and manufacture them at scale, and vaccines too. But we also need, along with that, a capacity to engage the public so they understand what's going on, what we do and don't know at each step of the way. As we're starting to detect the infection, hopefully understanding it and taking good steps quickly to contain spread. And respond. And that requires not just CDC, but also ASPR, our Assistant Secretary for Preparedness and Response, and it requires the healthcare system to act differently. We had heroic healthcare responses during the pandemic as New York and other parts of the country were hit first and then hit repeatedly by successive waves. Where we had struggled a bit more was in, to Janet's point, engaging people about whether they want to get vaccinated or not, for identifying people who are at high risk, making sure they had tests available and had access to treatments. That prevention, community-based side of healthcare was much more uneven. Again, there were some really bright spots, organizations that got out there and were already doing like virtual visits and knew who all our high-risk patients were and pre-positioned tests and had discussions with them or uses community health workers to help engage them. And there were a lot of parts of the country where we just didn't have that infrastructure in place. We had, could bring in temporary, vaccine centers at football stadiums, but that's not really an infrastructure that's geared to the fact that for any infectious disease threat that comes along, we ought to be able to identify it quickly, identify where and how it's spreading, contain it through these other steps. But that requires not just new accountability at the CDC, but I think some new accountability in healthcare as well. If you think about where we're moving in our healthcare system, it's more about, can we identify health risks before they progress? The technologies are there. Test and treat applies to virtually every health problem today. And it's not only medical responses that we need, but that is an important part of it. So there's a lot to learn here that we haven't really put together yet that I don't think is a partisan set of issues. But I really appreciate us coming together to talk about it. And so I've talked about some of the problems and some of the opportunities, and hoping the rest of our time we can move forward from that.
I was going to say, in some sense, actually, it's not necessarily even a surprise that the CDC struggled because we didn't actually necessarily set it up for success.
Yeah.
Right? Because we've tasked the agency with addressing public health everything.
Mm-hmm. Yeah.
And then we are surprised when there's a once-in-a-century pandemic and they focused on a variety of other components of public health, and that readiness and response function has atrophied.
So the CDC has a limited budget overall that has been relatively flat over some decades, took a hit with the budgetary challenges with the Great Recession of 2008 and hadn't really recovered by the time COVID came around. Just would emphasize is that unlike FDA, which is a national structure for getting safe and effective treatments to people and using them to protect and promote health, the CDC is, as Janet said, very much a federal agency, so most of its limited budget goes as kind of pass-throughs with some CDC oversight to state and local public health offices. There are over 3,300 state and local public health offices across the country, and with limited grant funding, and that funding through the way Congress appropriates for CDC split into a bunch of different silos, some of which are about emergency response, some of which are about other good public health goals, to your point, smoking cessation, maternal health, filling in gaps in our healthcare system around infectious diseases, HIV, patients that get fired by our healthcare providers. It's understandable that it's hard for them to put all that together. I think there is a path forward, and the new CDC director, incoming CDC director, has talked about this, more partnerships with healthcare, maybe more partnerships with FDA, certainly more partnerships at the state and local level with, in North Carolina, some of our effective responses were getting out into rural communities. Who's there and trusted? Well, like the Ag Extension Service, that can be a good point of contact for farmers and frontline healthcare providers, but they need support to do this. So it's something that, where CDC could help, can't do it alone, but also where healthcare and social service providers could be involved too.
Do you think that perhaps a more focused mission for the CDC with staffing and culture built around that could help?
It's a very broad mission. And if you look at, the CDC has on its website, it's kind of broadly supported in the public health community, this idea of what's called Public Health 3.0, which is recognizing that public health is certainly not just about hygiene and making sure the water's clean and the foods are safe and so forth. Important collaborations with FDA there too, I think. But also about all these opportunities with technology, with medical technology, all the opportunities with understanding how behavioral choices and constraints that people face influence their their health outcomes. But that is so broad. If you think about budgets, we spend about $13,000 per person on healthcare in the United States. We spend about $3,500, $4,000 on social services. All of those things affect health. spend about $300 per capita, $350 maybe, between CDC funding and other federal and state and local public health funding. You see how this has got to be a partnership in order to work better.
Absolutely. And although I would say for the CDC, the question is what is the return on the investment for the population in investment in, say, chronic disease? And is CDC the right lever to do that? And should another agency be taking on some of those functions, maybe at a more local or state level rather than a federal level? And that would allow the CDC to sort of blossom in its pandemic response and infectious disease response, and perhaps have a different workforce.
Yeah, I think we're maybe starting to take steps in that direction. I think it is another area where I think it would be really productive to have some discussions about, how can you do that better? So take the Healthy People 2030 goals,
Yeah.
So these are all goals out there,
And
but if you
evaluate
look
the
kind of
CDC.
below them, like, well, who's exactly supposed to be doing what to get there?
And also, every year we make new goals, or every 10 years,
Yeah.
and the population keeps getting worse on all the measures.
That's right.
So we're not doing something right, okay? So I
And
think
this is despite, by the way, us having better knowledge of what behavioral, non-medical steps can improve public health, and having better drugs, early diagnostics than ever before that also could contribute to all of these. CDC does not have the budget to be held accountable to get to those goals by themselves.
Right.
We're starting to see in many healthcare organizations, this is a CMS priority. You've heard about shifting from fee-for-service payment to paying for accountability for better health outcomes. So more payments to healthcare providers are moving towards, say, for diabetes. Did you screen your population of patients effectively? Did you get to effective hemoglobin A1C level, is indicating good diabetic control through a whole combination of mechanisms, new diabetes treatment, food is medicine prescriptions, help with engaging people in using personal health apps to get healthier. So that's something that CMS can help with. And I agree with your point about state and local levels. We're seeing a lot of really innovative work happening, across blue states, red states, Indiana, North Carolina, Massachusetts, wherever, on trying to integrate social services and community resources around people and have some tracking and accountability at the local level for sort of the equivalent of these Healthy People 2030 goals. But this is way bigger than something that CDC can work on alone.
Absolutely agree. And one of the questions to ask is should a function reside at the federal level, or should it might be better at the state level or even at the local level? And it's who is most effective to undertake the job and coordinate it. Along those lines, I had a question actually for you, Janet. I was thinking about sort of clinical trials. We talked about how the biomedical innovation complex works quite well.
Right.
And we're all thankful for that. The NIH is a powerhouse for basic science. What do you think do you think that there are lessons for what we should focus some of the NIH's translational science efforts on?
Well, I have long been a proponent of if the NIH is going to sponsor clinical trials, that they really ought to think about the infrastructure, funding an infrastructure rather than funding what I call the SCT, so I won't mention that here, but the small, not very good trials, right, that they have traditionally funded as part of like R01 grants and so forth. What we lack in the United States, because we have left the clinical development to industry, and that's fine, they do it efficiently, they do it effectively, and so forth and so on. But then when a crisis arises like this, or for public health issues that industry isn't necessarily going to pursue, right? Because they have a different objective or set of objectives. We really lack an infrastructure to do that. As Mark said, now we have the opportunity, for example, we could harness real world evidence. We could do large scale experiments. We could really see, because some of the things you raised, Mark, they cry for cluster randomization because look, we've been having the healthy people 2,000 for whatever 1,000 for 30 years, and we haven't made progress against. So we need evidence-driven or data-driven interventions, even social interventions, rather than best intention interventions that we keep doing even though they're not working. Okay, so I do think, but I don't think the NIH is set up for that, and I don't know the answer for it. But what I would say is there's a big gap in the public sector of research, and that is the huge gap on the clinical evaluation. It is a giant gap. And you wanted to ask about diagnostics. So the real issue there, the COVID diagnostics, I think, really took off. The Congress gave $1 billion, I think, to NIH for the RADx program, and they put in a program. They developed standards, okay, and reference standards, and serum, okay, and so forth. So manufacturer.
It's like a standard test bed. So you've got to test it.
Exactly,
Here's a quick
and
way
an
to
algorithm,
validate
and they
it.
helped with it, right? And so manufacturers were sending us COVID tests, and they tested them in 30 people. Okay, and they were supposed to be used by millions, right? And they didn't work. And this was universities too who did this, right? But if we had offered a standard evaluation protocol with that a third party could do, we could run those through very quickly and gotten a lot of those on the market because the data would have been generated.
Certification of conformity in a known test bed is something that is used in the telecom industry all the
Well,
time.
that's what I mean. This isn't rocket science. It's been around for like 20 years. But, so they were all out there, little diagnostic companies. They might have good PCR scientists and this and that. But, they didn't have the clinical, and people couldn't get a hold of the variants, and so forth. But if we pooled our efforts and pooled reference standards in place, you could run a lot of different diagnostic tests through there very rapidly, give the evidence to the FDA. It would be standardized, so we wouldn't have to question it, we wouldn't have to inspect it. And that's what happened. And when that happened, then all these tests became available because they could be easily clinically evaluated.
And these include direct-to-consumer tests, tests you can use at home with rapid response time. It might not be quite as sensitive, but still can be a really, really valuable part of detecting and containing an outbreak.
And one thing you and I are big proponents both of, Mark, is real-world evidence and moving trials out of what Janet would say are the small, not very good trials into a broader, larger community setting, right? Like HCA should have a massive clinical trials apparatus. Like all these large health systems in the community should have that. And that's a great, it should be part of clinical care. And so what do you think that the NIH's translational efforts could target to help promote that?
Well, I think NIH can help. I think FDA can actually do some further steps to help here too. And it certainly is a high priority for the current commissioner as well as Janet to try to make progress. The hardest thing about doing trials in a real world setting is that you actually have to deliver real world care. And the solution of, let's just expand our funding for traditional NIH trials by bringing in, protocol reviewers and local oversight of trial conditions and data collectors and all of that just doesn't lend itself to the delivery of care and routine practice. Remember, healthcare organizations are pretty stretched these days financially, so they have to do something simple. The good news is that we've got a lot better electronic data than we used to. A lot of that data, if it matters for payment, is pretty darn accurate. We've got healthcare systems that are no longer, working at the one-off clinician level. So we're not talking about a traditional small crummy trial that would have come from one academic at this one institution pairing up with a few of his or her friends, say we can produce a study where you really would worry about, is that particular clinician really implementing objective standards and the right kind of consent process, and are they collecting data accurately? We're talking about systems that have systematic implementation of electronic record systems, of clinical protocols supported by EMRs, whole teams of people who are working together. So holding those individual clinicians accountable for, well, how exactly is the trial going in the same way that we did in the old style, investigator-led research is just not right. And getting to ways of kind of certifying health systems as having good patient protections, consent, oversight, good objective data collection that they're already using for their own care, and their own payments in many cases are based on that data. That's the future, but I don't think, Janet, that either the NIH funding for sort of these platform kinds of practical randomized clinical trials, or frankly a lot of the FDA oversight regulations have yet matched up with the potential there.
Well, this morning before I came down here, I was talking to the people in the UK. Where there's a group there on the revision of the good clinical practice guidelines, which are ICH guidelines, and they've the pragmatic trialists, which is really what we're talking about here, have staged a little bit of a revolution against that, which is appropriate. I mean, trials should be fit for purpose, okay? And there aren't, quote, regulatory trials, and you should decide what kind of decisions you're going to make out of that information, and you should design the trial to yield that data and information in a reliable way. So I think we will be revising, including revising like who's responsible and how can you do distributed, and we've sent out some guidance and information on that, because we have to recognize that the world is changing and the way things are done is changing. That would have, but the question is Brian's question, I think, is what would have enabled the U.S. to put together more rapidly, clinical trials, say, out of warp speed. I had a tremendous amount of problems getting that done at enough scale, right? And it was because they were small extant networks, but we didn't have the kind of scope, say, that because the UK, the RECOVER trial, managed to incorporate even investigational agents eventually and test them, or they did a lot of repurposed agents, but they did.
That could be a good use for the NIH's translational research efforts, setting up those trials, or even helping come up with real-world evidence measures, like how do you clean EHR data, for example.
Yeah, but then you'd need a unit or group at NIH who's focused on clinical evaluation and methodology. And if you look around the country, we have some, but I'm talking about an institute, right? Where are the departments of clinical evaluation around the country at medical schools? There aren't any. This is a sideline for most people. It isn't supported by robust grant. So I think even for NIH, its traditional role could be, if they sort of open their eyes about this, at least to support not just the basic science, but the clinical evaluation and the science of clinical evaluation. That might be NIH's true role, not supporting the actual evaluation itself. That might be a bridge too far. I mean, they do some of that.
I think that's a really good point, because that could rapidly speed up development, decrease cost, and also increase access, all in one specific policy change.
Well, it might improve the quality overall in the United States of investigations. I've published on the fact that most of the trials that were set up in the United States by the academic centers were inadequate. They weren't adequately powered. They didn't enroll enough. They couldn't answer the questions. We had thousands and thousands, tens of thousands of patients enrolled in trials that were not able to answer the questions they were asking on your face. So, raising the level of expertise around clinical evaluation, not having it simply be, at warp speed, I had to bring in ClinOps people from industry, and they were the people who knew actually how to do this and get this done at scale. So, we just don't have that set of expertise in the government, except maybe some, points of light here and there. But you really need a kind of machine, to really get this done at scale.
This would be a significant change at NIH to do something like that at scale. I think the other pieces are lining up. I work with a group called Advancing Clinical Trials at the Point of Care Act Coalition, which includes a number of these health systems, which to Janet's point, just don't feel like the pre-market clinical trials are answering all the questions that they'd like answered. What are the long-term effects of these treatments? What do I do about, drug interactions? Is this the right dosage? If I have a side effect, what's the best way to manage it? And those are impossible questions to answer in a standard, pre-market NIH-type clinical trial. They are exactly the kinds of questions that you could answer if you had much larger scale platforms and were focusing on the key data elements to collect, since we already at that point have a good understanding of major side effects, mechanism of action, things like that. And these organizations that act at point of care say, these are the kinds of questions that we want answered, whether it's around cardiovascular disease drugs or the new diabetes drugs that may be very helpful for prediabetes, may be helpful for obesity, but may have some unknown as of yet consequences for with long-term use at higher doses. New treatments for neurodegenerative diseases, Alzheimer's, comparative effectiveness. I am not quite seeing yet the NIH big change to get there. One other possibility might be the new funding for ARPA-H. So this is a program that's intended to support advanced, transformative projects, and maybe a jump start here around a few platforms could lead to the desired goal of the ARPA-H program. Faster, better evidence and transformation.
I'm on the PCORI board, and I've been trying to push
And
them
PCORI could
toward.
too, yeah.
There was just a study published. This sounds like, why hadn't we done this? Electroconvulsive therapy versus ketamine for severe depression. All right, and so that's a little edgy. That's a little bit more, that. But those are the questions healthcare systems
Really want
and
answered,
insurers need to
Really want
answer. What should we pay for? Or if people, they have this chronic disease and they've been on this regimen and they're not responding or whatever, you need another, what should you go to?
Yeah.
And right now it's all like, well, my mentor taught me this, or this is what this
Or
is.
small, kind of extend your SCT, small, crummy observational studies?
Small, crummy observational studies, yeah.
And it is an art instead of
It's
it
an
being
art.
a science.
That's
which it
right.
could
It's
be.
not evidence-driven. Yeah, and that's much of healthcare right now, and yet it's amenable to actually hypothesis-driven, evidence generation if we'd only organize it a little bit. And that means, like Mark said, that those who would be participating in this healthcare system, insurers, have to see the value of this information to them. Yeah.
I think we'll open it up to questions.
A microphone is coming to you. There you go.
Thank you, Lou Gagliano. As a data person, we have more data flying around in this country that we are not using well. And I guess I'm thinking of Leapfrog, the Leapfrog group, who about 20 years ago revolutionized getting hospital data, okay? Measuring a good hospital and not on an ABCD scorecard. Pretty simple to understand. Yes, there's data behind it they're gathering to determine what is A, B, C, or D. What did that lead to? It led to, in part, value-based contracting. Because guess what? Insurance companies don't want to send who they're going to have to pay for, nor do the employers, to a D hospital. So why we can't take that lesson and morph it? And I'll give you one absurd example of an insurance company who's decided to pay for getting people to walk companion dogs for people at end of life, because that companion dog delivers more value to that person who's remote and alone than any other thing. So we have an example of what is going on the private side, and that we are not morphing to the public side. And it's about time that we grow up as a country and learn from what's going on, from the blue standards of care that are going on in North Carolina, Utah, Massachusetts, et cetera. Thank you.
I think it's a great point, and it just highlights how important it is to
shift out of the traditional way we've paid in healthcare for stuff that's done in hospitals and institutions, and recognize that all these factors influence health. To make that work, though, you need to, like Leapfrog really emphasized, you need to measure what matters and create a way of aligning payments with that. And a lot of this is happening in the private sector, as you said, but some of those examples are in Medicare Advantage programs. So this is publicly funded, privately delivered, with some accountability, and there's some things we can do to improve that program, but it very much aligns with the stuff we've been talking about here today.
I would say the challenge is in measurement right now, because we don't have those networks, because we don't have the ability to measure stuff with scale in the real world, and we don't and we spend billions of dollars on translational research, publicly funded, but don't have these sort of questions in mind.
We do. I mean, we do know the measures. It's like, this is like a measure of patient experience, caregiver experience. There's standard ways to do that. We've got digital tools that can help. They're not as widely accepted and they're not as widely used, but that's an issue where policy can make a difference. The regulatory steps like Janet was describing around, hey, if these measures, digitally collected remotely, could be used for clinical trials, including practical clinical trials, and if CMS would put maybe more emphasis on, paying for what people really care about, that could help advance these approaches too. Yeah.
What the knife edge you walk, though, is a lot of these. I have some friends who are actually involved in some of these programs, implementing or being insured, is micromanagement. So you want to value the outcome, not micromanage the people, because then they have to fill in, like the providers, a lot of forms, and I did this and I screened this for this, and pretty soon they are spending an hour on all this stuff that people could dream up that would be helpful for the patient. So I think that the design of the programs needs to be evaluated, and I think Medicare Advantage does that to some extent.
Trying, there's more we could do.
Again,
but
it should be evidence-based. Does this way of holding people accountable actually change their behavior?
Yeah.
Right?
And having that infrastructure to answer that question quickly in real time.
That's right, and that's my
Because
sort
we
of
don't
thing.
have that.
We don't have that, right?
And we had to, and you also talked about vaccinations and football fields, and I would take that a step further in saying it's fine to have the football field be the vaccination site, but that we should have the plan in place and the machinery ready to go to set that up quickly. And so a lot of, I think, lessons that we're pulling from this is that we need to be pragmatic and that we need to be flexible and ready to go, and that a lot of our infrastructure is not that way, and that infrastructure that's sitting there unused and has billions of dollars spent on it every year is not necessarily what we need.
Yeah.
We need the ability to rapidly scale and deploy.
And probably some creativity, because I think you need creativity in advance. So I think you mentioned ag extension services. Okay, so when we got the monoclonal antibodies at Warp Speed, we got them developed, we paid for them, we had them in hand, and we couldn't deliver them. Okay, I wasn't in charge of that for quite a while until I staged a revolution about it. Okay, we couldn't deliver them. And if we'd thought in advance, okay, who do people turn to? It turned out the ambulance services, the EMTs, they were fabulous at this. Okay, they knew their communities, but we had to send it to them, okay? I think the ag extension services for rural areas, they could pair up with the emergency EMT services and they could deliver like vaccine, but that's creativity. Like, who do the people actually interact with? Who do they work with? Who do they trust? Who's there? Okay, and then would we arrange to send them stuff so that we reach all our population? Because the football fields work if you live near a football stadium, right, or whatever, but then you need the personnel to give it and so forth. So I really think in times of peace, we shouldn't just think of the public health system and all the people in there. We got to think of who's capable.
And I think one of the threads I wanted to pull on there is you're also talking about a decentralized system coupled with some central organization.
Yeah.
But having EMS is not having someone in DC, Atlanta, Boston, Chicago telling them what to do.
Right.
It's they get the supplies they need,
Right.
and maybe there's some federal coordination, but that it is often a local or a state effort.
Absolutely.
And we can't underestimate their importance.
I agree, and that's where we need to think of that in advance, because it took us a while, and then we had to mobilize all those people. We had the dialysis centers; they are good at IVs and stuff like that, and the home health people were able to help with delivering the monoclonals and so forth. But we had to dream all this up in the middle of a crisis, and then reach out to all these people. I'll tell you, the ambulance people and some of the community organizers in different communities were fabulous at organizing vaccination and delivery of therapeutics to their people. But they weren't the people came to mind instantly.
Yeah. We are seeing some good examples of everything you said. So that's the good news. The challenge is, how do you make that scalable? How do you make it easier to replicate and sustain financially? And most of the funding for that, some of it's going to come from CDC and public health, but as I talked about before, there's just not a whole lot of resources there. A lot more around social service programs where many states, Indiana has done a great job of integrating eligibility programs and participation programs in their social programs, which can help a lot with these issues, and linking it to healthcare providers who are trying to address social needs for individuals. And on the healthcare side, lots of healthcare providers around the country are playing key roles in local and state public responses. The best responses around the country were invariably a combination of state and local government and business leaders, and especially healthcare leaders, including ambulance providers and so forth. But we aren't systematically giving them the data that they need. We've got fragmented public health data, we've got healthcare data that could support all of this with further steps like we've been talking about in CMS and our big healthcare payment programs. And I hope that's an area for progress. There are, again, some states and localities that are doing it well. This is all connected, Brian, back to your point about, what are the goals that we're trying to work on together, and can we get to some more real accountability? Are we truly ready? Have we done a real stress test for the next regional state response to a public health emergency with the right kind of federal support? Are we doing the right things to address other local public health threats like opioid use disorder, maternal health inequities, and things like that?
And I think going to that, actually, we often give localities funding tied to very narrow goals
and
without
very
providing
small fragmented sources of
right,
funding
and
from
so they end up with
different
like
agencies,
15, 20 different funding streams that are tiny bits of money with broad goals and no flexibility about how to use them and organize them.
That's not the right way to do it.
No, it's not thoughtful or practical. Yes.
Thanks. I wanted to give you an opportunity to talk a bit about various regulatory approval processes. So the acronym EUA became familiar to all of us during the pandemic, and so I wanted to hear a bit about the role of different pathways to approval, especially during a pandemic, how they're functioning, how they could be doing better. And I think it's important to talk about this because people sometimes can get confused about why things are approved, why approval is sometimes revoked, why it might take a while to get full approval, and so on. So what's the role of these different pathways within the FDA, and are they doing well? Could they be doing better?
Yeah, well, I think the emergency use authorization pathway is a very good one and functioned very well for the country and enabled the FDA to get out things. What it basically does, it's no longer investigational, and you don't have all the informed consent and all these, it's deemed as good enough considering the emergency that it could be made available, authorized for availability without being investigational anymore. So without an IND and all the different things that go along with that. On the other hand, it doesn't require and that's, I do think, what confused the population because, for example, for the vaccines, they probably had some of the largest vaccine trials ever done, okay? And we had a huge amount of data on safety and effectiveness of these. So we weren't cutting corners there, but there's all sorts of things required for reliability of manufacturer and everything that we could cut off in
Like,
an
is
emergency.
the vaccine going to be stable for a year?
Exactly.
Well,
It didn't
right.
matter.
Who cares, right?
It was flying off the shelves, right? So we could do all those things and have those flexibilities with the EUA. But I agree, I think the major problem with it is it confused the public. They were thinking it was a lesser standard overall, and they were getting substandard stuff where we'd taken shortcuts. And of course, this was combined with the social narrative that was out there, which was very confusing, I think, to the medical community, much of us at least, that, you know, this was some kind of plot or something foisted on the public, right? So I think we probably need to pay more attention, if should something like this happen again, to how we position this and what the narrative is around why we're doing this. We tried, but nobody's like really good at communicating extremely well these more complex concepts during an emergency. Yeah. But the actual mechanism functioned extremely well, and the FDA, you know, put out dozens of EUA products. And then, okay, revoked then would be revoked because more data came out that, you know, or there was a better alternative that became available, for example, things like that. And that's hard to explain to the public. That happens all the time in medicine. You know, we have a cancer drug and then we get a better one. Well, they aren't really, quote, revoked, but nobody's using the old one anymore because something more effective or safer came along. So explaining that natural evolution that is accelerated during a crisis is difficult for the public.
Another issue that we haven't solved yet, which is effective communication, especially in an emergency when some is known, the knowledge level improves and changes quickly, but lots is unknown, and conveying that in a way that's accurate and practical is another area I think where, you know, more of these partnerships could be helpful. I mean, CDC can be a good source of analytic information, especially if they're able to get good data. But if you look at national polls across Republicans, Democrats, people were getting their information from, you know, different frames. They do have some commonalities around trusting their local healthcare provider, clinician, pharmacist, trusting others in their community who could be allied, who could partner. You know, we're talking about like ag extension, things like that before, but that's a different strategy for not only, you know, describing, hey, this EUA has been approved, but for helping people get the right practical information for them from a trusted source about what it means for them. I don't think we solved that problem yet either.
Yeah, we had, and I know the CDC we had a huge partner network of all these different patient and consumer organizations and, you know, all kinds of organizations, and we had weekly phone calls with them, and we gave them materials, and we gave them talking points, and we answered their questions and everything, but it was still very difficult to get the sort of reliable, valid information out into everybody's hands and have it heard. And that might have been for other reasons, but yeah, I think there was a big effort to bring in the local communities and a recognition that those are the faith communities were reached out to, that those are the folks that people listen to and trust.
We are a country of countries.
Yeah, that's for sure.
In many ways.
That's right, yeah.
Well, I have one question actually I wanted to ask that's been sort of burning. It's about diagnostic testing. And so originally when we actually had the early stages of the pandemic, we didn't have access to tests. And there were a variety of reasons why that happened. And I guess my question for each of you is, what do you think we should do to make sure that that doesn't happen in the future?
Well, as I said earlier, I think that we ought to really have a very rigorous plan. And the plan is what Mark said. We get the PCR, we get the virus or whatever it is, the agent, we get it in. There is a collective, systematic effort to develop reference panels. We get serum from infected people. We get other possible interfering sera. We get all that, make a panel, and then we invite people industry, academic labs, the CDC, whoever, to contribute to that. Now you need a gold standard, okay, but we have that, we can do these, you can do the blots and you can do the PCR and everything on this reference panel and you can characterize it. And I can't even emphasize enough what an important development tool that is. And people do not have, you have to do testing of robustness and proficiency testing and so forth like that to make sure the test is actually doable in people's hands, right? But having these resources available to various parties so they could do rapid development and generate the evidence needed for an EUA, right? It just can't be, but we have to have a plan to do that rather than just put the plan together.
Just to add to that, I think one thing that I think there's a lot of agreement. There's a lot of issues where there's disagreement about how do we respond in the next public health emergency. But where I think there is agreement is that the technology is there through genomics and PCR to make available very quickly, and there will be other tests that build on it for more rapid findings and things that people can do on their own at home. But through our existing laboratory network, including not just the public health labs, which we kind of relied on at the beginning of COVID, and not just through CDC, but through all of the labs that want to help. We saw this in COVID with Trevor Bedford's lab in Seattle trying to do early diagnosis. So we've got the capacity to do this when there's a new threat. And so number one, we all would agree on is, can we get those tests out to healthcare partner organizations all across the country to enable us to do hopefully a quick assessment of just how much this new agent is spreading. And if you work with the healthcare organizations, all of these labs are connected via nationally consistent electronic standards in ways that could feed back that data, at least at an aggregate level, to local responders, each state and local public health agency, the healthcare organizations they work with, as well as the CDC and whoever is in charge of national planning for the emergency response at that point. Like I said at the beginning, we haven't worked that out yet. That seems like some common ground, and that could then couple that with Janet's reference testing for any new tests that come along to scale those up and make available the best ones. That'd be a really different response than we were able to pull off in COVID.
Absolutely.
Yeah, so Mark's talking about the very beginning as this threat comes through. We need really good laboratories to be working together to do that surveillance. They have to agree on the standards, okay? They have to get together. We had a lot of people who were fighting with each other, right, about this and that and the other thing. And then as that moves forward, out of that effort comes a reference panel, really. But you have to objectively decide you're going to construct that, right? And then
it's going to be a healthcare public health effort together.
That's right. Yeah, you got to get those samples from healthcare so you can create that. And then the diagnostic companies can really, they're the ones who can do this at scale, right? Let's get over it, okay? And so they can do the easy test, the plate test or the strip test. They could do all this stuff, but they need the tools. They need to have the substrates given to them.
They need a flexible platform upon which the multiple parties can compete to develop tests that meet a standard. And then on top of that, for rollout, they need to be able to have the logistics to get the test out, but then also get the data in a standardized form. So there needs to be standards development around public health and health data so that it's more portable. And then on top of that, you need to, sort of like Starbucks can measure the number of cups of coffee sold at probably each of their stores across the world, to be able to, at the local, state, or federal level, get those data in a de-identified and secure and
You made that sound a little complicated, but we do some things like this now. We do have electronic reporting for, like today, COVID cases from hospitals and emergency rooms. We did have some states and localities adopting electronic standards for sharing lab report data, positive and negative, and de-identified and protected. We just haven't done it nationally yet, and this seems like a great combination of what we can support nationally through CDC, FDA, and I would add CMS, and informing and supporting, very well done local responses that are faster, more informed, and therefore more effective.
Well, thank you. Thank you all for joining us. We'll end on that note. And hopefully, I think that we have a series of ideas and sort of policy principles for a bipartisan way forwards. And hopefully the next time we run into a pandemic, maybe 30, 40 years from now,
Maybe sooner, Brian.
maybe sooner, we'll be in a better place.
Right.
Thank you for joining us.
Thank you.
Thank you.